Good evening to all. I am Yogita and I warmly welcome you to our CellTalk webinar. In today's session, Dr. Vijay Padur will be addressing the research titled A Molecularly Integrated Grade for Meningioma. Our speaker Vijay is a senior scientist at Trenex who leads bioinformatics, genomics, and next generation sequencing research related activities in the organization. He is currently working on the neoantigen cancer vaccine pipeline projects. Vijay holds a PhD in life sciences from TMC Attract Homi Bhabha National Institute, Navi Mumbai. His PhD study focused on cancer genomics. Previously, Vijay has worked as assistant professor at graduate and postgraduate degree colleges as well. At Trinix, he has gained experience in scientific, operational, and administrative matters. So, without further delay, I would like to request Dr. Vijay to take the floor.
Thank you, Dr. Yogita. So as our routine CellTalk Journal Club activity, I have selected a paper, a molecularly integrated grade for meningioma. The original authors are Joseph Driver and others. So the title of the paper is a molecularly integrated grade for meningioma. The topic selected for this presentation is meningioma. Journal title is neuro-oncology, which has an impact factor of 13.029 and was published in year 2021. And this research has an impact of meningioma diagnosis and prognostication. The introduction. Meningioma is a tumor that has its origin in meninges. So these tumors, they arise from the meninges that form a protective covering around the brain inside the skull. And it has its origin from this meninges and it starts its growth there. Though it is called as brain tumor, as we have seen, as its origin is not brain, therefore it is not technically a brain tumor. This meningioma, this arises from meninges and they slowly grow inwards into the cranium as there is no more space for extra growth. It presses on the brain and therefore it might affect the functioning of the brain. It is generally a slow growing tumor and generally it will grow without any symptoms. The excessive growth of the meningioma tumor, if it continues, this will lead to the impaired activity of the brain and which might result as a seizure or lack of cognition, such brain functions. So meningioma, it is the most common primary intracranial tumors in the United States. It has a 35,000 new cases are diagnosed every year and the population prevalence is approximately 1 in every 100 adults over the age of 45 of age. So the diagnosis of the meningioma is primarily done by histopathological diagnosis. So currently used histopathological diagnosis method is the World Health Organization classification system. And this places meningiomas into different groups and these are different grades from grade 1 to grade 3, that is grade 1, grade 2 and grade 3. With increasing grades, the severity of the meningioma tumor increases and this is assessed by using the histopathology. Now this is a primary measure which is used to predict the outcome based on what kind of grade it is assigned to that particular tumor type. And depending upon that, the post-surgical treatment decisions are made. If it is grade 1, that means it is very slowly growing and just debulking of the tumor, that is removing as much of the tumor as possible. That is the primary aim. And then in those cases, the post-surgical radiation therapy is not given. In grade 2 and grade 3, as these are more advanced grades, and in grade 3, the tumor can be more aggressively growing. So in those particular cases, post-surgical treatment such as radiation therapy may be advised. So in that case, what kind of post-surgical treatment is to be given and also the prognostication of that particular tumor, it heavily depends upon its classification. Now this particular classification, the World Health Organization classification, it has its limitations. The limitation is that the behavior of the meningioma tumors, it does not always conform to the assigned WHO grade. So if we see the grade 1 and grade 2 and grade 3, grade 1 are more benign and as you move forward to the grading scale, it will become more aggressive. But the clinical behavior of meningioma does not conform to this particular generalized idea. Grade 1 tumors might show aggressive development and also may show recurrence. So some of the grade 1 may show recurrence, but some of the grade 3, which are aggressive, may remain indolent and may not grow at all. So this limitation is detrimental to making accurate treatment choices for the patient. So currently, we need some better treatment, better classification system so that treatment can be managed effectively. So the authors of this paper, they have proposed a new system of grading of meningioma, and they have included molecular features of the tumor also. So WHO grading system only includes the histological features of the tumor. So these authors, they have tried to integrate the molecular features of that tumors also, as molecular characterizations of tumor is becoming much more common right now, because sequencing and other allied technologies are more common. So the limitation of WHO grading system, it results because there might be inter-observer variability, because histopathological diagnosis is done by a histopathologist. So pathologist to pathologist, there might be difference in opinion about what grade this particular section of tumor might fall. So difference may be due to that. And also there might be potential undersampling, as these tumors, if they are large in size, then one particular part of the tumor might be represented more into the histological slides as compared to some other parts, and therefore the entire representation of the tumor might not be there. And there is also possibility that these histopathological features may not actually predict the malignant potential of that particular tumors. So these are the limitations, and they have tried to integrate different molecular methods such as methylation profiling, copy number variation profiling, and DNA sequencing and RNA sequencing into the grading of the meningioma systems. Now, what are the present challenges with respect to the meningioma classification? Is that the behavior of the meningiomas does not always conform to their assigned WHO grade. So some histologically benign lower grade meningiomas may develop recurrence, but aggressive grades might remain stable after the surgical resection. So in order to alleviate these limitations, they have done this research with the objective to devise an improved, broadly accessible, prognostically relevant grading scheme for meningioma. So in that, they wanted to formulate a molecularly integrated grade that is simple to apply, transparent, scalable, accurate in long-term prediction of clinical behavior. So this represents their entire methodology in summary. So as you can see here, this is one particular case that they have taken as a representation. So as a meningioma tumor is growing into this scan image, so they have identified what is the location of that particular tumor, then what is the volume, then surgical resection, how much of it was resected, what was it complete resection or a subtotal resection, that is only a part could be removed because of some surgical complications, and then what was the post-operative treatment that was given, and this was followed up to the 5 year. Then diagnosis, as it is made by histopathological diagnosis. So this shows a histopathological image, and depending upon its features, it has been assigned a histopathological grade, and that is WHO grade 2. And molecular profiling of that particular tumor was also carried out, and different characteristics, molecular characteristic, that is 1p loss, then chromosome 10 loss and chromosome 14 q loss. So these characteristics were identified, and then this was analyzed. This is just one sample, but multiple such samples, around 599 samples they analyzed, and they found the clinical outcome, that is time to recurrence of that particular meningioma. And then they modeled this integrated scheme, and they have shown that the integrated grading scheme is better as compared to the WHO scheme. So in detail, so they analyzed 699 tumors, and they took clinical annotations such as clinical history, tumor location, radiographic features, and volumetric contouring of the tumor, whether it was completely resected or it was a subtotal resection. It was analyzed, and histopathological review according to WHO classification scheme 2007 and 2016 was carried out. So In the molecular part, they evaluated these meningiomas by molecular characterization, and that is genomic characterizations. So all of these different meningiomas did not have all the profiling characteristics common. So the number of different methods were available for which data was available. So DNA copy number profiling by microarray analysis, and then oncopanel targeting mutation profiling, which contained 227 to 447 cancer associated genes sequenced, that was available, and it was used for inferring the copy number variations. And then methylation based copy number variation data was available, and RNA-seq based derived copy number variation data was also available. So different technologies based copy number variation data was integrated into this analysis. So this slide gives the idea about the samples that those were used. In total, 950 meningioma cases were available. So discovery cohort, validation cohort, and molecular cohort and external validation cohort. These were the different groups in which samples were distributed. And as you can see, there are different overlaps and non-overlaps into the samples. So different techniques are available. Some tumors had microarray data, some had oncopanel data, and some had like this 118, both the data was available. So this data was used to independently validate the results from the other method. And then methylation and RNA-seq based data was used for inferred copy number variation. And they also used an external validation cohort comprising 55 patients. So this shows the results of their analysis. And here each row represents, each column represents one particular sample. This top panel, it shows the different features of that particular sample, that is grade of the tumor. As you can see, most of these are the grade 1 tumors. Then the second number is the grade 2 tumors, and the least amount are the grade 3 tumors. So grade 3 tumors, these are less common as compared to grade 1 and grade 3 tumors. Then we have subtypes, and we have mitotic index and atypical features and different chromosomal alterations. So here 1p loss is shown in blue. So it is common into some proportion in all of these subgroups, and 30% of the total cases they had a chromosome 1p loss. So as you can see, all these loss and gains, these have been summarized. And these different molecular characteristics are apparent in this entire cohort of 527 meningiomas. So here they have used this molecular characteristic, like which molecular alterations are more common across the different meningiomas. So there are different subtypes also, anaplastic, rhabdoid, clear cell. These are different subtypes of meningioma that they have analyzed. And this particular most recurrent copy number alterations, they have further utilized into their grading scheme. So as you can see, 1p loss, chromosome 1p loss, chromosome 22q loss, chromosome 14q loss. So these are some prominent chromosomal alterations that you can see. These were evaluated for analysis into what is their significance into the molecular characteristics of those meningiomas. So this slide, it shows the inferred copy number alterations. So inferred copy number alterations means the copy number alterations that were derived indirectly from some other form of data. Here methylation data and mutational oncopanel data and RNA-seq data, these were used for finding the copy number alterations. So here also we can see the same common alterations, 1p chromosome 22q loss, these were found, and there was a 96% concordance was observed between those patients in which both type of data was available. That is microarray data and this type of data. So to develop an molecularly integrated grade, they use machine learning approaches such as lasso regression, gradient boosting approach, and random survival forest approaches to find the most significantly associated molecular features that are associated with the meningioma recurrence. So as you can see, there are different sets in which these different molecular alterations are falling. So 1p, 6q, 10q, 18q, 19p, and CDKN2A, B mitosis, these were found to be significantly associated by using all three methods. So here they developed a molecular integrated grade. So for that, they assess the hazard ratios of each individual copy number alterations, and they gave a particular weightage to each particular molecular alteration. So as you can see, CDKN2A, 2B loss, it has the most hazard ratio. So this red means it has a significance less than 0.05, and these black bars, they represent the uh, confidence interval, and that is it has a significance greater than 0.05. So we are only concentrating on those which are red. So here, as you can see, the hazard ratio is larger for some of the molecular alterations, and they have used and identified it by using the univariate Cox proportional hazard analysis. So here, this represents the development of molecularly integrated grade. So throughout this analysis, they identified these high-risk molecular alterations. As we have seen previously, 1P was and CDKN2A, 2B, these were having the large hazard ratios. So all of these were given a certain points. If they are present in a particular sample, they will give 1 point for that particular molecular feature. So in that way, they devised a grading scheme. So if the points are 0 to 1, it will grade 1, molecular grade 1 will be given, and then molecularly integrated grade 2 will be given if the points are 2 to 3, and if points are more than 4, then molecularly integrated grade 3 will be given. So by this method, they reassigned or reclassified these 527 meningiomas in their study cohort. So as you can see, there a lot of reclassification took place. So 30%, 32% of the cases were reclassified. So this shows WHO grade and this shows integrated grade. And as you can see, some of the WHO grade 1 were shifted to integrated grade 2 and grade 3, while some of the WHO grade 3 were shifted to integrated grade 1 and grade 2. So this shows why there was inconsistency with the WHO grade in the prediction of recurrence of the tumor. So some of the grade 1 can behave aggressively also, and some of the grade 3 can behave in a benign fashion also. So here this shows the concordance of WHO grade and the integrated grade, and they show most of the classification was maintained. WHO grade 1 and integrated grade 1, 87% concordance. WHO grade 3, grade 2 and grade 3, they showed 31% and 72% concordance respectively. So here they evaluated the integrated grade as a predictor of meningioma behavior. So as you can see, this progression-free survival analysis, it shows WHO grade 1, grade 2 and grade 3 as this is the time to recurrence up to 144 months. So as you can see, the grade 3 are having more quick recurrence as compared to grade 1 and grade 2. Same is seen here, but as you can see, there are multiple grade 3 that were getting reclassified also. So this shows better recurrence prediction or outcome in the integrated grade. Then they also checked whether the integrated grade 1, grade 2 and grade 3 was how it performed as compared to the all WHO grade 1. So here, as you can see, integrated grade 1 and grade 2 are comparable to the WHO grade 1, but integrated grade 3 has shown quicker recurrence, the reclassified cases. So here in the second panel, they show the difference between the integrated grade 1, 2 and 3, each of these, as compared to the WHO grade 2. So as you can see, as the predictable outcome was seen into the recurrence of the meningioma. Now here, as a predictor of behavior, they have compared WHO grade 2 and 3 and integrated grade 1 and WHO grade 1, which were integrated grade 2, 3, which were reclassified. So here, as the reclassified, they are showing the again quicker recurrence as compared to WHO grade 2, 3, which were reclassified as integrated grade 1. Now here, the brain invasion, those integrated grade 1, which showed brain invasion as compared to the integrated grade 2, 3, which showed brain invasion. So there is clearly a difference between these two cases, which were separated or compared as taking the integrated grade. Here, they also analyzed how much is the accurate this integrated grade. So they have used time-dependent AUC curve analysis, time-dependent average precision analysis, and Brier curve. So here, as you can see, the integrated grade is performing better. Here also, time-dependent average precision integrated grade is performing better, and Brier curve, which estimates the accuracy or prediction error, it is also behaving or giving a better outcome. So validation of integrated grade among multiple patient cohorts. So here WHO grade and with molecular alteration 1P loss, then 1P6Q loss, 1P6Q and integrated grade. As you can see, there is a difference as compared to the WHO grade with the prediction of error, as the integrated grade is showing the least amount of error here. As the time progresses, the error is decreasing. And here they have checked chromosome 1P loss as a higher risk predictor. Then validation of integrated grade among the multiple patient cohorts. So they have used 2016 WHO grade and 2021 WHO grade and integrated grade. So prediction error, as you can see through the Brier curve, it is also very low for the integrated grade. Here, they compared the CDKN2A B's molecular status for the recurrence. So there is no difference in the CDKN2B heterozygous loss or CDKN2AB homozygous loss, though they are showing quicker recurrence as compared to those in which CDKN2A and B were wild type. Then they have checked the prediction error of WHO grade and integrated grade in a completely independent validation cohort, and there also we can see that there is a less prediction error with the integrated grade. And then in the external validation cohort, they also see the same thing, that is integrated grade is showing better prediction performance as compared to the WHO grade. Now, what is the impact of the treatment of resection, surgical resection? So here you can see that gross total resection and subtotal resection, GTR and STR. So subtotal resection, that means tumor was not completely resected. So it is showing quicker recurrence as compared to gross total resection, that means tumor that was completely resected. And here the classification is based on the integrated grade. Integrated grade 1, integrated grade 2, and integrated grade 3. So the difference is much more prominent in integrated grade 1 and grade 2 as compared to the grade 3, because grade 3 itself are more aggressive tumors. So here, primary as compared to primary tumor and recurrent tumor, primary tumor show very less probability of recurrence as compared to the recurrent tumor. That means recurrent tumors are more prone to recur again after the surgical resection. So here they show a nomogram for clinical utility. So this nomogram, it gives a comparative analysis of different factors: integrated grade, extent of resection, tumor volume, and tumor state. Tumor grades 1, 2, 3, extent of resection, whether it is subtotal resection or gross total resection, and their associated hazard ratios. So as you can see, as the grade increases, the hazard ratio also increases, and they give a certain point for each status that is found in the tumor that is being analyzed. So these nomogram points, these are added each. So subtotal resection and gross total resection, the hazard ratio is less because most of the tumor is getting resected. And tumor volume also, if it is less, it has less hazard ratio as compared to the more volume of the tumor, and therefore a larger point is given. So if the feature is having bad effect on the tumor behavior, then higher points are given as compared to the mild features. So once you add all these points, you get a particular digit that can be compared here in this risk nomogram. So in this risk nomogram, as you will have points higher, so it will give you the recurrence risk. So as you can see, as you go higher into this scale, the recurrence risk also increases. So by using this nomogram and this grading scheme, you can predict the recurrence of the tumor in the patients. So conclusion, the molecularly integrated grading scheme of meningiomas, it is a significant improvement on the current WHO grading system. And then integrated grading scheme, this framework can be adopted by clinicians because this molecular testing is becoming more common, and copy number variation data will also be available more frequently, and therefore it can be integrated into this scheme, and a better prognostication of the patients can be performed. All said and done, this system has some limitations. The limitations are that the mutational coverage was incomplete. That means some of the significant mutations were not covered in many samples, that is third promoter mutation, BAP1 mutation, as well as C1 mutation. And also certain subtypes of WHO high-grade histological grade, that is clear cell, choroid, rhabdoid, and papillary, they were underrepresented into this sample cohort. So for those, how much it is applicable, how the system is applicable, it is not clear. And then again, a Simpson grade, which is the most precise measure of the extent of tumor resection, it was not available, so it was not included into this study. And methylation signatures were not available for the study in this institutional cohort. So earlier studies which had shown the classification impact of the methylation features, that comparison cannot be done. Impact of the research, the molecularly integrated grading scheme of meningiomas overcomes the limitations of the WHO grading system, and it improves the prediction of progression-free survival prediction into the patients. And this research lays foundation for more effective grading meningiomas, genomically informed clinical trials, and improved patient management in the future patients. Thank you.
Thank you so much, Dr. Vijay, for this informative and enlightening talk. Now I open the floor to the audience. Dr. Nupur asks, considering molecular features is definitely a better approach for grading. This research considers chromosomal loss. What is the role of somatic mutation in grading? There may be some risk genes which are mutating.
Yes, meningiomas have fewer genes that are found to be somatically mutated. And as suggested, they have used a subset of patients in which they have used oncopanel, in which few cancer-related genes were analyzed, but that data was not available for all the patients. So therefore, they have not included this into this grading scheme. But definitely, these mutational data will also assist into the grading system.
Thank you, Dr. Vijay. Hope it clarifies your doubt, Nupur. Are there any questions from the audience? No more questions are coming from the audience. So again, I want to thank Dr. Vijay for the excellent presentation. I'm sure we all have gathered so much information on meningioma and its grading system. Before we conclude this webinar, I would like to inform everyone that our next presentation will be on 17th January 2023, and I will be presenting on research titled Grading of IDH mutant astrocytoma using diffusion susceptibility and perfusion weighted imaging. I would like to thank you all for your time and kind attention today. Thank you all for being here. Hope to see you all at the upcoming presentation. Thank you so much.